It's nice to have an opportunity to talk about not necessarily this local campaign, but to talk about moisture-associated skin damage, because it's not still reached the same avoidable harm status as pressure ulcers, but potentially from some of the content of this presentation and your own knowledge and experience of moisture-associated skin damage, you might feel the same as me, and that it does sit there as a potential avoidable patient harm. So there are some images. I don't know in the audience how many of you are clinicians, hands-on TVNs. So just a warning that there are some photographs of skin damage for the squeamish people amongst us. Sometimes I put myself in that category, some of the things that we see as tissue viability nurses. So just for context, I will just touch on a little bit about what moisture-associated skin damage is and show a couple of examples, just in case you're not necessarily in a clinical role. So moisture-associated skin damage, that I might start saying MASD because it's very mouthful, is an umbrella term, so it's an overarching term that includes all types of skin damage caused by repeated or prolonged moisture on the skin. So typically we know these as being urinary and fecal incontinence, wound exudate, perspiration, and stomal fluid. So just a reminder of the four main types. The top two are certainly the most prevalent, and incontinence-associated dermatitis is the most prevalent amongst the types of MASD. So incontinence-associated dermatitis is what it is. It's damage caused when urine and/or feces make prolonged or repeated contact with the skin. And intertriginous dermatitis, that's often shorter to intertrigo, is when you've got two surfaces of skin in contact with one another, and the friction, the rubbing, and the moisture build up between the two surfaces of the skin causes the soreness and condition called intertrigo. So we commonly associate this with being in the natal cleft between the buttocks, underarms, groins, and under breasts. And then the last two prevalent types are peri-wound moisture damage and peristomal dermatitis, and they're from volumes of wound fluid or stomal fluid. Just some images to show a couple of examples. Example of intertrigo. So this is very common. We see lots of people come into our hospital with this as a recurring theme, and some patients develop it while in hospital or at home. Examples of incontinence-associated dermatitis that you might be familiar with. So the picture on the left, you can actually see, they're both sacral areas, you can actually see that is overhydrated, wet, soggy skin, and that skin is then particularly vulnerable to the effects of pressure shear or friction, that rubbing mechanical force. And the picture on the right is classically what clinicians might call a linear lesion, and the skin becomes so overhydrated in the crease in the natal cleft, and this patient's also got some perianal skin loss, you can see as well, but it almost looks as though someone's took a razor blade and just shot down the skin with it, and often the descriptions that the skin looks as though it's split. Examples of, I think we'd all agree, more severe harm caused by incontinence. The picture on the left is from urinary incontinence. It's a picture commonly used in presentations. You may well have seen it before if you've heard anything to do with pressure or moisture. And that's the ammonia in urine, almost, well, it is a chemical, and it causes almost a chemical burn, and that looks excruciatingly painful. And the picture on the right, bear with me because just wanted to give you a bit of background about this lady. Was a patient in our intensive care, and as you do, I'm going to be very honest now, as you do, it gets to a certain time of the day, well I do, and my phone rings and I think, do I answer it? Because what am I going to get pulled into? You know, some days you need to leave. This was one of them. So typically I'm here till 5:30, 6 o'clock, often a bit later, and my phone rang at 6:30. and the Cisco phone tells you where the call's from. So I could see it was from a room on ITU, and it rang a couple of times. Then curiosity got the better of me, so I answered the phone, and staff nurse was very upset, very concerned. Asked me, could I please go and see this patient then. She didn't know what to do. She felt at a loss. So I did go and see this lady, and this is the photograph that I took at that visit. And before I even approached her, she was wincing in pain. This photograph shows a blue tube, which is a urinary catheter, and the kind of brownish tube, which is the FlexiSeal, the bowel management system. So that contains liquid feces. And they don't contain 100% in my experience. So before I took this photograph, there was liquid stools on her skin. So as a nurse, you can't leave a patient with that. So we had to clean her skin, and we did it as gently as we could, but the noises from her and the winces from her were really quite haunting. And you can see the damage there, the kind of islands of more than superficial damage, the chunks of tissue that have been eroded from fetal incontinence. And just to give some context, this lady had been incontinent of liquid stools for 24 hours. So it wasn't days and days, it was continuous bowel openings. So it was literally as fast as she was opening her bowels, she needed to be cleaned again. There's an argument for earlier use of the FlexiSeal, but the damage was done. So at the time, as a TV tissue viability service, we were evaluating a couple of new products, and one of them was an advanced skin protectant, and it was back in the office. So time was ticking on, and I said to the nurse and the patient, who could communicate to some degree, but not wholly, I said that I'd come back first thing in the morning and we'd get this on, and we'd found already from evaluating the product that it immediately helped with the burning sensation that patients often associate with this type of skin damage. They'll say it's itching, burning, stinging, because you've lost all that superficial barrier and your nerve endings are exposed, so it is going to be painful. So I said I'd go back first thing in the morning. I'm always in 7, half 7, so I didn't even switch my computer on. I grabbed me product and I went up to ITU, and I was told that she'd died overnight. So I'd not known her personally, but I was devastated that a patient had developed that skin damage and had died in what could only be imagined and unseen and witnessed as excruciating pain. Obviously, she hadn't died of the skin damage, but we talk a lot about patient experience and end of life. She wasn't immediately end of life either, or was known, but patients surprise us sometimes, don't they? So I made that was like a personal driver for me, as well as the national drives that are associated with moisture-associated skin damage. But that was certainly a personal one for me, and I said to myself that never would a patient have that extensive tissue damage from moisture again. But of course, we have national drivers, and this document that you may be very familiar with, because as TVNs and perhaps quality leads, patient safety leads, this may have come under your radar. So it was NHS improvement document in 2018, and it was predominantly about pressure ulcers. So it had lots of 29 recommendations in it, and a lot of them were associated with pressure ulcers. So it was, the terms avoidable and unavoidable shouldn't be used. The term category should be used instead of stage and grade. And there was lots of others about how you record and report pressure ulcers, but there was one recommendation that was about moisture damage, and it was the first of its kind in a national document, recommendation 25, and it's saying that MASD should actually be counted and reported in addition to pressure ulcers, and the rationale for that was that at the time, and arguably still, the capturing the the number of instances of MASD is still a little maybe inconsistent in some areas. And if as an organisation you have got systems in place to know how much MASD is developing, what extent of a problem you have, then this recommendation is prompting that you then start thinking about quality improvement initiatives that could be taken to improve and reduce your incidence, which is what we try to do. So a background to the Minimise Moisture campaign. We were seeing patients admitted with MASD, and we were also seeing patients develop it during their inpatient stay with us. Many instances, of course, they are minor harm, of course they are, and but harm nevertheless. But there are some where skin can be quite badly affected, and we talk about pressure ulcers, and the always pressure to reduce pressure ulcers as organisations. Some MASD causes far more harm and consequences for the patients in terms of quality of life, pain, etc., than some pressure ulcers. And that's kind of one of the reasons why it's questionable, really, why it's taken so long for it to get some national recognition as being a patient harm. So in Liverpool Heart and Chest, we started to formally collect the data before the recommendation. So it had been talked about in the nursing press for a couple of years prior to the NHS improvement document. So we kind of wanted to know what our baseline was. So we got that. We also did a little bit of a look at what products were being used, because even though we're a small organisation, we're only 230 beds. And some of you now will be thinking, 230 beds compared to my 1,200 or 1,500. We are small, but and there's definitely advantages to doing QI work in a small organisation. But we still had some issues, and certainly what was being used to clean a patient's skin after they've been incontinent was one of them. And you may know what's used in your organisation, you may not. It's only once you start looking and asking the staff and making it like a point of trying to find out. And Hibby scrub, hand soap, really any kind of liquid that you could put in a bowl of water with a cloth. But shaving foam, I kind of get that, because there's foam cleansers, isn't there, the pH balance that you can use on the skin and leave on the skin and cleanse off. Maybe staff thought shaving foam had some of the same properties, but it doesn't. So that was a bit of a shocker. And we began our improvement work as long ago now as January 18. So we wanted a local guideline that was just dedicated to MASD. So previously it was like a tag on the pressure ulcer guideline, and we wanted its own guideline so that we could then kind of audit it on its own, and it just kind of made a bit of a bigger impact with staff that actually this is an issue in its own right. We introduced a new cleansing wipe, and we developed a protocol for prevention management of AD. And we thought, oh, that's great. Take job done. That's all fabulous now. But it wasn't, because actually nothing changed. Nothing changed that was notable anyway. So Minimise Moisture campaign, what is it? It was primarily, I'll explain that little chap in the top left corner. Chap, I say chap, I don't know what gender he is, but looks angry, doesn't he? So it's largely an educational campaign, and initially it was really just aimed at raising staff's awareness. Hadn't really concentrated much in terms of training education around moisture damage. So it was something that really rested on the TVN shoulders to assess it and offer advice. So it was about to raise awareness, get a bit of ownership. Obviously it was a local quality improvement. But then it became a little bit bigger. So obviously we wanted consistent, standardised treatment. Ultimately wanted to reduce the incidence of MASD. And then we kind of wanted to monitor the outcome initially, but then it's something that actually warrants ongoing monitoring and review. So it did become a little bit more robust than just an awareness campaign. So I'll explain what it is. Minimise is an acronym. We love an acronym in the NHS. I love an acronym generally. So I did a literature search of what was in the current press, best practice around MASD at the time. I'm glad to say since then nothing's changed. Otherwise this would become quite outdated quite quick. So I had a look at the literature, and then I intentionally was kind of trying to pull out a bit of an acronym, but it kind of fell out. But I was a letter I short, so I'm not good at countdown, by the way. I don't those 9-letter conundrums. I would never get them. But I had lots of letters, minimas, that just kind of fell into the word minimise on the page, apart from one I. But there was no problem finding another I. So we then had the basis of something that was then built on to develop into an educational tool and campaign. So I'll just explain what each of them represents. And it, as I say, it does mirror the best practice, international best practice recommendations for prevention and management of moisture-associated skin damage. So the first one, management of incontinence. Obviously, incontinence is a huge risk factor for developing pressure ulcers, and 1 in 5 patients who develop MASD to the sacrum will go on to develop a pressure ulcer. So obviously, patients who've got urinary and fecal incontinence, it's important to have a plan in place to protect the skin and reduce the risk of IAD. Obviously, where possible, finding out the cause of the incontinence and fixing it would be the best idea. And there are reversible causes, obviously, UTIs, diuretics, constipation, diarrhea. And then following that assessment of incontinence is making the right choice of the earliest opportunity. My lady in ITU, there was an argument for why hadn't a Flexiseal been used a bit earlier. And one of the main drivers for using a temporary insertion of a urinary catheter or bowel management system is to maintain skin integrity, and that's absolutely the right thing to do. And then eyes inspect the skin. Skin inspection essential in pressure ulcer prevention and essential in MASD prevention as well. And it is close skin inspection. Sometimes, particularly in some patients with natal clefts, you do really need to part the waves and dig deep to get to the skin. So close skin inspection of any areas that can be affected by these fluids. Nutrition and hydration, always important. We know this because when you're deficient in something, it actually presents itself as a skin problem. So we know that, health and well-being in the skin. So it's important for skin to be as strong and as healthy as it can. Your skin's that physical and chemical barrier between the outside and the tissues underneath your skin. And that barrier function is critical. I'll talk a bit more about the barrier function in a minute. And then this is the one I was short of, so I made this up, but it's actually very relevant as it turns out. Implementing a plan. So it's all very well kind of recognising the patients who are at risk of developing it, and that's a good start as well. I identify the patients at risk, but then there's got to be a plan in place. Prevention's always better than cure, and anyone with incontinence is going to be at high risk of developing MASD. More moves. So not only repositioning and changing the position is an essential part of every patient's pressure ulcer prevention, it also aids cooling and evaporation of moisture from the skin. Moisture becomes trapped in skin folds, particularly, so think of your patients who are less mobile, bed-bound, chair-bound. They're at quite high risk of developing MASD. I had a question a couple of weeks ago about a patient, what more can I do to help this patient, because she was a wheelchair-bound patient, and she had this recurring cycle of MASD, natal cleft, sacrum, buttocks, behind her thighs, so all the areas that are in contact with the chair. And of course, we might be looking after patients, dyspneic patients who sweat profusely. We find actually, particularly in our critical care, it's a hot environment anyway, and then you've got reasons why the patients are hotter, sepsis, dyspnea, etc. So a lot we can do again in terms of microclimate, which might fit in with this, in terms of using moisture wicking products, changing bed linen a bit more frequently. that type of thing. And then I is identifying moisture damage correctly. So there are differences between pressure and moisture, and it's not easy sometimes to actually assign the right etiology, because there can also be both. So there can be skin damage that's caused by pressure and moisture. I had a classic again only a few weeks ago. So I'm not talking here today saying that we've solved the problem 100%. We haven't. We still have incidences of moisture damage. And we had a patient who developed your typical linear lesion. I don't know if any TVNs are listening to this who have a similar experience. And these are the classics: typical linear lesion, discounted for days as just minor harm, just a small linear lesion. And then 2 weeks later, we get a referral. It's a category 3 pressure ulcer. So understanding the differences, close monitoring, and there's lots of guides and tools around about the show the differences between pressure and moisture. So the location of it, the size of it, the depth of it, the characteristics of it, that type of thing. And skincare. So we talked about implementing a plan for prevention and management. Skincare is one of the biggest core components of that plan. It's really important to think about what products are being used to cleanse the skin, what bioproducts are being used. Do you need an advanced skin product as well? And educate. So education's a key thing. We use the Minimise as a tool to kind of structure our education, because it, as I say, it kind of captures really much of the best practice recommendations that are out there, and it's educating staff as well. So, you know, we'll see patients who've had this as a recurring problem. It's embarrassing to them. It's embarrassing, because patients are often associated with poor hygiene, and it certainly can be a factor. But we've seen patients who've got better hygiene than you or I would ever have, and it's still a recurring problem for them because of the skin folds. It can be a challenge. So just to focus, again, I would never normally advocate products. That's not the point. The point is the best principles. But I will just say 2 game changers for us have been these 2 products. Ultrasoft pads, the plastic backed incontinence sheets that you may still use in your organisation. The damage that they do it's not seen. It's seen once it's too late. But there's some great videos to show the difference in those blue plastic backed sheets and products such as ultrasound pads in terms of how they will manage that fluid and remove it away from the skin, so that the skin is actually then dry to touch. And blood, wound fluid, incontinence and sweat as well. So it's a big problem for us. And Kavlon advanced skin protectants, it's a game changer in terms of getting that an advanced product, one that can really hold its own against constant prolonged repeated exposure to particularly liquid stools. I wanted to mention them because they are game changers if you're at all in a position where you're looking at products. So we see Minimise Moisture as being a bundle of considerations. This little chap, if you haven't already worked character, if you haven't already worked out, is meant to represent a drop of moisture. So a drop of urine or feces or perspiration or wound fluid, and obviously the no entry sign. We wanted a campaign that was going to get staff engaged and listen to us. So a cartoon tends to colourful, it's a bit bright, and people will look at it and know. And we've had like JP conversations about it. It's you're going to think I'm sexist now, but man, we said, oh yeah, it must be a fella, look at him. But we've had a lot of fun with just this as a character, and the more staff will engage, the more you're gonna I've got their attention. We had, as I say, we actually had quite a lot of fun with this campaign. At the start of it, we printed off these A4 posters, laminated them, and we hid them in the clinical areas, in the wards and on critical care. And then when staff found one of them, they'd get in touch with us and they'd win a bottle of Prosecco. We maybe didn't think this through, because what the staff started to do, we didn't tell them what we were doing at the time, but they got got wise to it. And then when they saw us on the ward going into the linen room or the treatment room, they'd let us leave, and then they'd be straight in after it, searching the place. So a little bit distracting potentially of the shift. Didn't get any complaints. It's fine. And then they get in touch with us, get the Prosecco. We'd go to the area at some point, ask if we could take the photograph of the weekly bulletin. They all said they didn't want the photograph taken, but they clearly don't, as though they're unhappy here. And then we used basically every communication forum that we had available to us. So the weekly bulletin, we had computer screensavers. We would talk about this at every meeting, every forum. I actually asked if I could do a presentation to our exec team. We did it as an A5 quality improvement, so like a bit of a poster. A3, sorry, apologise. It's like a large poster on the wall. So all the execs, so the chief exec, director, nurse, and medical director, etc., were all there, and I printed and laminated the photograph of our patient on ITU, because it's important that we get the right people to understand what the challenges are in A, looking after a patient, and B, preventing this type of skin damage. But also, so you got their backing and their support. So we had posters, banners. We visited all clinical information, clinical areas with information. We did have some promotional items as well. So look, it wasn't the only intention wasn't to reduce. It isn't always a qualitative patient outcome. So this wasn't our only outcome measure. We did staff survey, patient survey as well, but did it have any impact in terms of reducing the numbers? So 2018-19 is the blue line, and the following year, last year, was the red line. So we are working consistently above, obviously COVID in that April, the start of the red line, where everything just went a little bit awry. We developed a promotional video, which is on YouTube if you search Minimise Moisture. I'm going to play for you now. It's only 2 minutes 30 seconds long, 2 minutes 29 seconds long. I just need to, in order for this video to come up, I just need to click on the next slide and back again, maybe once or twice. So I do apologise, just bear with me. And at some point we should see the, there we go, start of the video. So this is just a couple and a half minutes long.
Julie, we can't hear the sound.
Nope, sound's gone.
Okay, bear with me, everybody. Doesn't seem to want to go to the next slide. There we go. I'm not sure if you had sound on that play. I apologise if you didn't have sound. Although if you look at the video yourself, there's some music, quite kind of upbeat, jolly music. Gets a little bit irritating after the second minute. So, but it is worth a watch with sound just to see if it's a different experience for you.
Simon's put the link for it in the chat as well, so people can access it afterwards.
Great, thank you. So the next thing we did was develop a toolkit to support the implementation of Minimise moisture. This was a bit cathartic actually, because this isn't necessarily what we did. This is how I'd do it again if I was doing it again. So again, it's pertinent to the Minimise moisture theme and campaign, but it actually includes really just a bit of a quality improvement approach for any local kind of quality improvement initiative that you might think about doing. It's split into these 6 sections really. Identifying your stakeholders is important, knowing what your starting point is, scoping what your staff know, what your patient experience. Patient experience at MASD could be, and pictures can be very useful when you're liaising with stakeholders. And then it can be an opportunity to look at your products, look at your protocols and your policy. There's a bit more about the Minimise moisture campaign in there. And then obviously it is important if you implement anything, stakeholders are going to want to know what impact you've had. For this campaign, there are these kind of promotional merchandise available, and they're available on the TVS website as well. So I put it in an article in Wounds UK, so there's a lot more detail than I've had time to talk about if you wanted to look at that. And I just wanted to end so that we've got a good chunk of time for any conversation and questions and whatever, to just briefly say the advantages of doing any local campaign like this. It's just an opportunity to engage staff and patients to raise their awareness. It massively gives a platform to raise the profile of an issue because it gets people talking, and that raises awareness. It also gets buy-in, and sometimes you need that. You need the clinical buy-in. You need maybe the financial buy-in to support some improvements in practice. It enables effective change. It gives an opportunity to show visible leadership, and that focus on outcomes and monitoring improvements. Learn from my mistake and really think about them before you. I think as nurses, we see a problem, we see it needs to be fixed, and we jump in. The planning stage is important, and ultimately it's about remembering why we do anything in our job, and it's to improve patients' outcomes. So thank you for listening to me. I will stop sharing my screen and come back to you, Neil.
Thank you very much, Julie. Can I just check with yourself if it's all right for us to be able to, I'm going to make a little resource folder that I can share with people who are here and those who couldn't make it, of the recording from today, also with the publication in Wounds UK. Is that okay to share that?
Yeah, of course.
And I thought we might say that. And also to share your slide set if that's possible.
Yeah, absolutely fine. Yeah. Can you
Okay,
confirm I've entered my screen?
Sorry?
You can no longer see my screen.
Yeah. We've now lost your presentation and you're there in full glory.
Oh.
So yeah, I will be sharing all of that later. But if you now want to have a word with Julie, please put your hands up, and any questions, we'll field them, and hopefully Julie can answer them for you. Here we go.
Yep.
Can you see the chat, Julie?
I can.
So I've got a question from.
Yeah.
Okay, you got that one.
Yeah. So Haley's asked, is it possible to use Minimise in other trust stars campaign? Yeah, absolutely. Just to say that the character is trademarked, but it doesn't matter. It doesn't mean that you can't still use that in your campaign. Yeah, that would be great. We always say there's no point in reinventing the wheel. If someone's it's the same. We all have the same issues. We all have the same problems, and if there's a structure already there, then that's great.
Yep, Josie will be sharing that. And we've got a hand up. from Adele O'Neill. You got a question for Julie? Unmute yourself. I'll unmute you. No, where are you? Can't hear you if you're talking, Adele. Sorry.
Can you hear me now?
Oh yes, there we go.
Oh, okay. Hi, Julie.
Hello.
Hi, really good. I had a look at the little video yesterday and before I confirmed that I was going to attend today. And I was going to ask if I could use it as part of my, because I've got a presentation and I was going to incorporate it into my part of my presentation on moisture. And obviously I would have said, oh, well, this was the Chest Hospital in Liverpool that put this together, but it's a very good video and it's the type of videos that I think people respond really well to, and like you say, an acronym as well, they absolutely love that.
Yeah, it's in the public domain. It's on the Tissue Viability Society.
Oh yeah,
website.
and Wounds UK as well. So yeah, it's fantastic, and I'd like to be able to use it. So thank you.
Do you know that video? I wanted a video as an extra, just a different something different to look and listen to. So I asked a guy called Matt back in our communications to put something together. He put that, it's proper homemade. Honestly, it's so he put it together in about 4 minutes.
Oh, you're
I
joking.
gave him the content and he put it together in literally a few minutes. But it's short and it captures the key stuff. So
exactly. No, it's say congratulations to him.
I will feed it back to him. I will. Yeah.
Yeah. Do.
Thank you.
Josie, you got your hand up.
Have you muted everyone, Neil?
I have. No, I haven't muted everyone. It should be to unmute people, but how do you unmute people?
People people should be able to unmute themselves.
Oh, okay. Josie, can you? There we go. Oh, microphone's not working.
Oh,
Could be a long
type your question, Josie.
Yeah, just put it in the chat.
So Josie's just typing a question.
In this, while we're waiting for Josie's question to come through, I'm just going to put my contact details into the chat box here. If anybody wants to join up to the Harm-Free Care Network, where obviously we run such events as this, please just either email myself or connect through Twitter, and you'll be more than welcome. We cover a whole range of topics within harm-free care, so it's not just one topic, because there are many topics that come under this. So please feel free to sign up, refer a friend, bring a friend, we don't mind.
So Josie's asked, do you use Cavalon for all severity of MASD? We don't. Some organisations do just use one company's products for all severities or different different points in time in a patient's care plan. No, we don't, and the only we use someone else's barrier cream, someone else's Wickham product, so we don't know. But I wanted to mention those couple of products because they were game changers for us. And again, if there's so many products available on the market, as TVNs or other members in the organisation who are tasked with what you use, the cheapest option might be the best, but sometimes it's not. The most expensive product doesn't necessarily mean it's the best either. But as clinicians working in the NHS with the cost pressures that we have, we want each product to be cost effective. So we want it to be a price that reflects the effectiveness of it. And both of these products are that. I hope that answered your question, Josie.
Nice.
Anyone else got any hands up? Hands up, baby, hands up. No. Oh, hang on, Paul.
So Paul said in his organisation, start off using a barrier wipe but you've seen it being abused. And another local organisation had that same problem when they introduced a cleansing wipe. Their experience was that it was, you know, we will suggest that 1 or 2 wipes is all that's needed, but staff just continue to keep using handfuls, or they'll use it actually as a full body wipe when it's designed to actually be a continence care wipe, if they're the wipes that you're talking about, Paul. We haven't found that, to be fair, but it is definitely a risk to consider. And if other organisations were going to bring in a wipe, it is important to include when and how to use it. Yeah, so Paul, you've seen staff wiping beds with them.
Oh,
Yeah, one wipe doesn't fit all, but that seems to be the move now, doesn't it? There's lots of wipes available for different things. So some organisations are going to, instead of soap and water as a bed bath type wipe, and then we're talking about particular continence wipes for those vulnerable, just for those vulnerable sites. And then with COVID, there's wipes everywhere. So yeah, it's a tricky one. Yeah.
Oh, hang on, another one.
We do still use, the cleanser wipe that does have a barrier film in it, but we also have a barrier cream and an advanced skin protectant as well. So we haven't introduced a wipe at the expense of losing our barrier cream. There's definitely a place.
Any more questions?
No more hands up. I can
No.
see. Well, I think you've got a lot of requests to share your work, Julie. So thank you very much indeed.
Melanie's made a good point. The majority of wipes aren't suitable to go in the macerator equipment that goes into clinical waste, and clinical waste is incinerated, so it doesn't contribute to landfills, which is a point that a colleague mentioned that she got quite a lot of ethical consideration, environmental considerations. So just to mention that it's part of clinical waste, and most organisations' clinical waste is incinerated. It doesn't go to landfills. So it's a good. All of these considerations are important, aren't they?
Does your wipe contain dimethicone?
So it does. I don't know if you're trying to narrow down which one it is. I think I mentioned it actually at some point, but yeah, different ingredients in different barrier products. Some are more effective and certainly have more favour from the likes of David Fiogli, who's a well-published author on skin, and similarly UPAP, Jackie Fletcher, all names like known in tissue viability would advocate that. So Hayley said there is still a lot wrong out there despite education, absolutely, and it's pat drying the skin, which is why using a wipe negates that, because the wipe will air dry, so you're not having to use one of those towels or a cloth on skin which is probably already vulnerable from constant repeated exposure to urine or feces. So that's one of the main advantages to use a wipe, is it means you don't need to dry the skin with anything else and cause that mechanical. Is that Mitchell or Maloney? I'm sorry, so you don't use when you use hands. No, Cavalon continence care wipe, you don't need to dry at all, just air dries. But again, if you are using water and a cleansing product, the main things is pH balance, because otherwise that's disrupting your own skin's natural pH barrier, which is slightly acidic. Water starts to shift it into alkaline, and then soap, if it's not pH balanced, shoots it right into the alkaline state, which then becomes very risky for bacterial and fungal infections. So a soap substitute and pattern skin dry. There's an argument for pattern skin dry never actually gets the skin dry. So allowing a bit of time for air dry as well helps. Yeah, so Hayley's plus some people are using the wet wipes as dry wipes, which leaves the skin wet. It's about educating, isn't it? And kind of make sure staff know what products are for what and how to use them, because even a wipe, you wouldn't think it can be misused. Absolutely. Nicola's put, in terms of care home staff and residents at risk of MASD, would you recommend a particular product? Of course, weighing up the cost implications and the availability is important. In community, different challenges in terms of what products you can get, as whether or not in the care home, whether or not that links in with a local wound formulary and whether or not it's on that. Some wipes aren't on FP10, so they're not available on prescription, so they have to be ordered. Different supply routes of ordering, so you'd have to maybe look into that. We actually met with a local nursing home because we wanted to use Minimise Moisture as a campaign and go in and do it all. So we wanted to launch the campaign, we wanted to look at their products, we wanted to help them rewrite the policy and a protocol. And we went and did our baseline orders. So we went in and we looked at everyone's skin and we noted who had pressure and who had moisture damage. And then we were going to launch, and then COVID started, and we've not been able to get back into the nursing homes. And it wasn't deemed enough to do remote learning with them because we wanted to do like the whole thing. So I don't know, is it for me to recommend a particular product? There are so many out there. There really are so many out there. Most barrier products are gonna be okay. Most barrier creams are going to be okay. I've mentioned the Cavalon Advance. Ultrazor pads in a nursing home, I could think of not a higher risk group who would benefit from them. So check if you're using those blue-backed incontinence pads, that they are the worst thing for keeping moisture on the skin, and that damage, they are the worst thing. Joanne's asked, if using Minimise, how would you like us to reference me? You don't have to, really, I'm not bothered. You really don't have to. If you wanted to, Liverpool Heart and Chest is fine. Hayley, as put during COVID, it was sad when families weren't allowed to visit the care staff. So I imagine that's staff going and purchasing their own, purchasing soap for the residents there. Oh, I know people do, and so people were buying cheap soap and the damage that can cause but it was well intentioned. It was well intentioned, but it potentially does demonstrate. I just iterated that even water can change the pH of the skin. So yeah, just a pH balanced one obviously is going to be better for the skin. Though other soaps they strip out all the oil, and we're covered in, speak for myself and say this, we're covered in sweat and oil, and that's what creates something called the acid mantle, and that's what protects our skin from bacterial and fungal infections. So yeah, a pH balanced one is as good as it's going to get.